XYZ doc told me that I had the worst back that they've ever seen, or the worst knees that they've ever seen, or the worst shoulder that they've ever seen. I feel like statistically, it would actually be impossible for all of those things to be true. You're telling me that this person was the worst, and then also this person was the worst that you've ever seen?
They're tied.
That's crazy. That's crazy. And they're tied. They must be tied. It must be a tie. All right, what's up, JT? Welcome back, man. Welcome back to our, our official second episode.
This is the official one, right? The first one we were just, I don't even know what we were doing. We didn't even know what we were doing the first one.
Yeah, we really had no idea.
We still don't really know what we're doing, but we have, slightly more of an idea.
Very true. Very true. Yeah, we've been workshopping some names and trying to figure out the direction.
I think we spent more time figuring out the names than we have the topics and like what the research is.
Hey,
that's the most important thing about the podcast. That's what they say.
That's what they say, And honestly, I think that'll just leave for some really good, organic, authentic conversation.
That's it, man.
And so I'm excited about it. Well, man, we're gonna kick off really our first substantive episode, if you will, talking about healthcare and how much it sucks, right? And really, why does healthcare suck is the thing that we're going to deep dive into today. And I'm really excited to have this conversation with you because I know that we both have similar experiences in the world of healthcare, treating patients, but then also being in slightly different fields. You being a physical therapist, me being a chiropractor, we have also some different perspectives as well, right? So we see some things through the same lens and other things through slightly different lenses. And so I think that'll bring a nice balance to all of this. And really, I guess I just wanted to toss this out to you. What comes to your mind in terms of why did we decide to choose the topic of why healthcare sucks as our first real substantive episode?
Right. No, absolutely, man. And I think to me, it really defines why me and you wanted to start this podcast venture. And that's to educate the people. I mean, that's what we're out here to do. And we want to educate in a way that is unique and something that probably they haven't heard before. We're just trying to talk to people like we're their friends. We want them to feel like they're getting talked with by a colleague, a buddy that's on their side, as opposed to getting lectured at by somebody that's in a white coat that has 20 other patients to talk to that day that might only have 5 minutes to say the diagnosis or whatever they're going through. So we just want to give people another resource to educate with, and that's I know both of us are so passionate about education.
Right.
I know that feels like my purpose in life, and I know that we've talked about that, and so we just felt like this really defined why we're doing this, and I think there's a lot that you can learn from this episode.
Totally. And I think really one of the big things that we landed on as we were kind of talking through this preliminarily was the system of healthcare ultimately is designed to help people, but really for a lot of people, they feel unheard. And from certain perspectives, it can actually put them in danger, right? And so we're coming at this from a standpoint of how do we help people advocate for themselves, right? And educate themselves in terms of, really sticking up for themselves with their own health, and being their own advocate that allows them to enter into the healthcare system with confidence, right? But then also get the results that they're looking for ultimately, right? So, I mean, I guess when we think about all of that, we should just start with the bad. What's the bad news here? What do you see as being some of the biggest problems in our healthcare system? And maybe even from as your perspective as a physical therapist, and maybe I'll talk about it from my perspective as a chiro as well. But what are some of the big problems that you see with our healthcare system now? And maybe what are some of the things that you've heard directly from patients' mouths in terms of their frustrations with how they've been treated in the healthcare system?
Yeah, no, I think from the 10,000 foot view, just looking down on the healthcare system and then kind of going into the anecdotes that I've heard from patients is how I'll break it up. Yeah, looking at it, I'm seeing just a lack of time that most practitioners have with patients. And that's when we talk about the system. We're not out here attacking doctors. We're not out here attacking professionals that are trying to help people. At the end of the day, they chose that job because they want to help people, but the system is not allowing them to. And what I'm hearing from patients is that when they are with these doctors that are telling them about their diagnoses, they're spending very little time talking about some of the things that truly matter, such as the biopsychosocial approach to pain that we're going to talk about. Yeah, that's another episode, by the way. But they're not spending time to get to know the patient. They're treating them as we talk about it a lot, treating them as a number and not a patient, or treating them as a diagnosis and not a person.
Right.
And we're going to dive into that later. But some general anecdotes that I hear from patients numerous times is how they go into a doctor's office and they get a diagnosis, and they're hearing these words that are very, very scary, very unthoughtful in terms of how they come off. So an example would be someone goes in and they're looking at an MRI of their spine, right, and the doctor has told them, I'm sorry, this might be the worst spine I've ever seen. And I'm like, dude, and like that, and I'm asking this, by the way, like I'm asking this in my subjective with a patient, meeting them for the first time. Tell me what's been going on. This is what they tell me. This isn't one patient. And so like multiple patients are telling me, like, I just keep getting scared by these doctors telling me that this is the worst they've ever seen. They don't know what to do. What do you expect this person to leave there with? Like, if you're leaving the office feeling more scared than you walked in, that's an issue. That's the overarching issue to me, is a miscommunication, if you want to call it that, and just leaving patients with more questions than answers. That is a product of the system, I think.
Sure.
That doesn't allow the time that is necessary to treat patients the best way.
Yeah. And we talked a little bit about this, off air, but the thing that always comes into my mind when someone tells me they'll say, yeah, the XYZ doc told me that I had the worst back that they've ever seen, or the worst knees that they've ever seen, or the worst shoulder that they've ever seen. And the number of times that I hear that during a week blows my mind, to the point where I feel like statistically it would actually be impossible for all of those things to be true. Yeah. Like, at some point you're going to run out of providers who have said this is the worst XYZ that I've ever seen. And it's like, wait a second, you're telling me that this person was the worst and then also this person was the worst that you've ever seen?
They're tied.
That's crazy. That's crazy. And they're tied. They must be tied. It must be a tie. So like, that is bananas that you could have so many people having the worst conditions that you've ever seen. And not only is that, what I don't know is, like, do you think that is something that is, are they trying, like, let's give the providers who say those words, right, the benefit of the doubt, that they are trying in the patient's best interest to have them take their condition seriously, right? But, from a positive outcome perspective, we could say, okay, someone's coming in and let's say they have low back pain and it's kind of like, it's a disaster, right? And they need a lot of work, right? Whether that's rehab or, whether that's a surgical intervention or whatever it might be, right? That they need a lot of work because it is pretty rough, Do you feel like providers are using that terminology to scare people into maybe ascribing or buying into their mechanism or their approach of how to fix something, right? So you think of, like, a chiropractor saying, like, hey, you need a year's worth of care in order to get better, right? Or maybe it's a surgeon is like, hey, we have to do surgery yesterday, if you want to get this better, right? If you don't do anything now, by the time, if you wait another 10, 20 years, you're going to be paralyzed. It's like, those are the that's the verbiage that I hear people say sometimes. And I guess my question is, do we feel like this is something that people are trying to do to say, hey, if it's not with me, then this patient might not do anything. And then truly 10, 20, 30 years from now, they are going to be in a really, really bad spot if they don't do something now. Or do we feel like this is a scare tactic that is, just trying to get patients to spend money at their office? These are the things that I think about a lot. Like, what is your your basis or your rationale for saying something like that to somebody, right?
Yeah, no, it's a tough question to answer, and I think everyone's a little different in how they might answer this. But I tend to think more positively. I like to think that most doctors are looking out for the best interest in their patients. But then I start to hear these stories over and over and over again. At first, I was just writing them as a one-off. Maybe he was having a bad day, whatever. But whenever I think about how many patients are telling me these stories, how consistently, it starts to infuriate me. Like I'm a pretty chill person. This actually makes me mad. This makes me mad, to be honest with you, man. Like it's an issue, and I've started to research it more. And one interesting thing that I found that is discouraging is they did some research over the COVID pandemic, and they saw that because certain surgeries were not being done during COVID, like elective surgeries that might be considered non-essential. When they were not doing those, healthcare lost a lot of money. 42% of healthcare revenue loss was because of because they weren't doing surgery. So they see these numbers, right? Totally. And I don't like money talks, man. Like it's something that I don't like to think about, but it is the reality. Like the medical field is a business like anything else, and these hospitals are looking at those things, and they might see that these surgeries are they're really necessary for our hospital to continue to be profitable. That goes through my head, and then I looked up more research, and I saw that 53% of surgeries are technically unnecessary. What unnecessary means is they're not looking at the other potential options like conservative care that essentially provide the same benefit without having to go under the knife, without having to go through the medical costs, without having to have the risk of these post-surgical complications. So that really made me mad. And there's certain surgeries that are higher on the list. Typically spine being the top one, knee replacements typically higher on the list. Not all surgeries are non-essential. We're not coming after it like that. It's just I think we need to be a little bit more skeptical of the system for sure. In a safe way.
For sure. Yeah, and let's be clear, right? Surgery is a very amazing tool.
Absolutely. It's not like that.
Incredible in so many different ways.
Yes.
But I think the nuance here is, like you said, if over half, let's call it half for just for the sake of easy numbers, right? Half of surgeries performed are unnecessary, meaning that there are 50% of people who have undergone a surgery could have done something else that wasn't a surgery and gotten the exact same outcome. And my question to you, JT, is how many times have you seen somebody who's had a previous surgery for a body part, and then they end up in your office anyway?
Mm-hmm. That's like half my patient caseload.
Exactly.
Yeah.
I would say the same thing for me too. I would say close to half of my patients have had surgery for something, right? And then they have eventually ended back up in my office anyway. Mm-hmm. And I think over time, that number is probably dwindling down a little bit to where people are starting to pick up on this, right? Mm-hmm. And they're starting to see this, and I think they're starting to become attuned to the fact that this might not be the only answer for them, and they're trying to avoid that as much as possible because, let's be real, there's a lot of complications that can come with surgery, infections, right? There's so many different things that can come with that, right? Let alone like a quote failed surgery. Mm-hmm. There can be literally life-threatening things that happen. Just going under anesthesia can kill you, mm-hmm. right? Odds are very low, but it can kill you, Mm-hmm. And so it's like the chances of somebody going into a procedure and not walking out of that procedure alive are so much higher mm-hmm. than them walking into our office and mm-hmm. then not leaving alive, right?
Yes.
Like infinitely times higher. So to me, and maybe this is some of our bias just in terms of our profession, but to me it would be like, let's exhaust all the options that we possibly can on the conservative front before you go down that route, because once you open the skin, once you go under the knife, there's no going back, mm-hmm. right? And so many times we were talking about even with the literature on knee replacements, right? And looking at how function levels pre-knee replacement surgery are typically no worse or no better than function levels post-knee replacement surgery. So in other words, whatever your life looks like pre-knee replacement, it's probably going to look exactly the same post-knee replacement. Now, there's, not all joint replacements are created equal, right? So hips tend to do a whole lot better, right? Like a hip replacement can be a drastic change in somebody's quality of life just because of their mobility and how much they're able to do, especially now, within the last, the new advent of the anterior approach for a hip replacement being such a better recovery process than the posterior approach, that you have a whole lot more options there. But even just taking the knee replacement as one of our case studies, let's say, it would make sense to me that somebody would want to do everything that they possibly can before going under the knife, knowing that whatever function level they can get to before that procedure, that's pretty much what they're going to get afterward. Pain levels might be a little bit better, et cetera. I get that. But, in terms of what they're able to do with their life, which is what a lot of people really care about, it really doesn't change a whole lot. So I guess that kind of leads me into my next question, which are what are some of the big things and big conditions that you see are being mistreated in healthcare right now? And for the sake of this conversation, let's stick to mostly musculoskeletal conditions, right? The things that we see on a daily basis. We're not talking about systemic issues or crazy levels of whether like inflammation or cancer, anything that's like that. But let's talk about musculoskeletal conditions specifically in terms of what are those conditions that you see in your office that someone comes to you and says, man, I've seen 2, 3, 4 doctors before you, and you're the first person to tell me this. And to you, you're looking at this and like, why isn't this so obvious in terms of what's going on? Like, this should be so standard. And yet these people, like, we're having to give these revelations to people for the first time. That's like, no, like, I'm sorry that everything that you've been told up to this point is just, it's either short-sighted or it's incomplete, or at most it's inaccurate, right? What are some of those things that you feel like you're seeing?
Yeah, no, there's two that come to mind to me. One being the big one, low back pain. The second one being a labral injury, either hip or shoulder. But before I get into that, to your point, it can be very frustrating as a provider to hear that this person is coming in with these previously held beliefs, sometimes for 10, 20 years that they've been dealing with this. They're coming into me with all these fear avoidant patterns, these beliefs about their bodies that now I feel the responsibility of breaking down, and I know that that's going to take some time. So that in the midst of talking to them, I have to calm myself down and kind of get to a point where I can meet them where they're at while still not trying to dwell on all of these previously held beliefs. So asking those right questions is so important, which we will talk about, and I'm sure in future episodes. But getting into those two diagnoses that I talked about, low back pain is the big one. 4 out of 5 people in their lifetime will have some bout of low back pain. Everyone has it eventually. So we talked about the spinal surgeries being one of the most unnecessary surgeries in the world. And that's one of the ways that I see this being mistreated, specifically spinal fusions. I've seen a lot of really bad outcomes with that, just in the terms of the patients that I see. Not to say that everyone that has a spinal fusion is going to have a bad outcome, but they're not being taught about the biopsychosocial approach to pain. Again, we're going to talk about that in another episode, but they're not understanding that the MRI results that these doctors are showing them don't necessarily correlate to the pain that they're having, but they see these things. They're very visual. They see this. It's an easy answer. I have disc degeneration at L3, L4. That's why I have all this pain. Oh, it makes sense. Now I don't want to bend over. Now I don't want to hurt my disc. Like, that's just not how it works. And we don't need to dive into everything about how we go into treatment, but it is helping the patient understand that low back pain doesn't necessarily correlate to what they're seeing on an MRI. And then we go through a movement assessment. We might find out that it's their right ankle that might be causing the issue because they're not having the mobility of the ankle. They start to compensate up the chain. That's just one example. So they're not looking at the full body, they're looking at that. And then the other one would be labral injuries. That's specific to me that I've seen mainly in the hip. Actually, I see a lot of partial labral hip tears. And when somebody sees a tear, they want to fix it. They want to, all right, there's something torn. We got to sew it back together because it can't heal on its own. I got to get this if I ever want to run again. And there's been numerous research studies that show the same outcome with non-surgical treatment of a partial labral tear versus surgical repair. And that's something that I start with and talk about, and just helping them understand the function of the labrum, what it does. It helps provide stability to the hip. There are a lot of other things that provide stability to the hip, mainly the muscles being active stabilizers, things that you can train. And then let's focus in on that. What can we control? We can control the muscles. We can control the nervous system. Let's work on that to help the body relearn how to get around this little labral tear, whereas most people come in thinking that it's torn. I'll never have the same hip again, where that's just not the case. So those are two specifically that I've seen a lot. I'm sure you've seen several. Is there any that stand out to you?
No, yes, there are. I'm glad you brought those up. I think like the low back pain one is so important because it's, like you said, 80% of people will get low back pain at some point in their life, right? And if you were to directly go to MRIing every single bit of low back pain that came into the office, you would probably see some pathologies on those MRIs. But the big question is, are those pathologies actually the thing that's causing pain, or is it something else, right? And if you're only looking at a static image, it's really easy just to look at something and say, well, clearly this isn't normal, so this must be your problem. But then when you take a step back and you actually look at the patient in front of you, there are many, many times where that thing that's on the MRI has literally nothing to do with how they're presenting. And so we have to take both into context. And there are certain times where, let's be real, getting an MRI for certain things is really valuable because it can be more clues. It's another piece of the puzzle, but it's not a nail in the coffin. And by no means is it the final word in terms of what's actually happening here. We have to look at both. We have to look at how somebody is testing, how they're presenting, and if necessary, what their imaging looks like. And at that point, we can make an educated decision on what the next step is going to be. It might be surgery, right? There are certain red flags there are certain presentations that's like, dude, we don't touch that, That is something that we refer out for, and it's very important to understand and know where your limits are. But I think for the purpose of this discussion, I think, and for our biases in terms of what we see, is we see so much more of the opposite. That's like, God, if we could have just met you 10 years ago and we could have stopped you from having that surgery.
The amount of times I've thought that, man.
It's like, God, if only I met you at your younger self, like you would be in such a different place now. But you can't really say that to somebody. You can't put that blame on them because it's not their fault, right? And so you just have to, and there's also no use in ruminating on that. It's just like, okay, where are we at now? Where do we have to get to? Boom, let's execute, right? So I think that's one thing. I think, you're right in terms of the labrum tears. I think we talked about a meniscus is in that same camp. I would put that in the same thing, like the meniscus of the knee, same situation, right? We know that in that outer third of the meniscus, right, we get good blood supply to that outer third. And so if the tear is in that outer third, we have pretty good indication that things are going to heal and that you'll probably be fine, right? And that the surgical outcome versus the non-surgical, pretty stinking good, right? And then, things change depending on the location and the size of the tear, et cetera, right? And even for the hip as well, there are certain tests that we can do to indicate, right? Like the log roll test, for example, is a very good test for the leg that shows that, like, hey, if you lay flat on your back and we take your leg and we roll it back and forth, like we're like rolling a pin, what's that thing called? What's the thing that you hit dough with?
Don't ask me about kitchen
rolling
questions.
Pin.
I don't know.
Yeah. Rolling
pins. Yeah.
Right, you roll it back and forth like a rolling pin.
Need to phone my mom real quick.
Exactly. Hey, Mom, what's that thing called that you used to?
To make my cookies. What is that?
What was that called?
Yeah.
It's a rolling pin, JT. That's what it is.
Yes, ma'am. Sorry.
Yeah, sorry. Okay, I'll talk to you in a month. Okay, so
That's good.
all right, so you take the leg and you roll it back and forth like a rolling pin, and it's like, man, that lights them up. Ooh, chances that needs surgery, pretty good, right? But most labral tears that I see in my clinic are negative for that, and so we know that there are certain things that we can do in office that oftentimes are not done in an orthopedic office that can help say, with reasonable assumption, what's the best path forward for you? Or is it a 50-50 toss-up, right? Is it going to be that, yeah, you could get surgery and probably do fine, or you could just not and also do fine, right? And so there's, that's the thing where I think when we get into patient empowerment and having them be educated in terms of making decisions for their own health, it's going to be helpful to know, like, just because you get one answer from somebody doesn't mean that it's gospel, And so to become educated and aware of that, and I hope that's one of the things that we can do is help people learn more about that so that they can make those informed decisions for themselves. And by the way, right, like none of this is medical advice for individuals.
Right.
We're speaking in generalities here. And so it's important, we hope that this is just more information that people can use to help them and their physicians make, good decisions for their own health. I think for me, that was a long-winded way to answer your question.
I love that.
But I think when
good.
I look at one thing that pops into my mind that I know you and I both see a lot of is tendinopathies. So tendon injuries, tendinitis is what a lot of people know it as. But in the medical community, we call it tendinopathy, right? Which is a degenerative change to a tendon, right? So for those who don't know, a tendinopathy is essentially your tendon, which connects your muscle to your bone, right? So your muscle becomes a tendon, which then anchors onto the bone, right? And tendons are super cool and they're very strong, right? They're like steel cables. But sometimes through, either through age or through different injuries, right, we can get fraying to those cables that can then become painful, right? And that's called a tendinopathy. And we look at a tendinopathy and we think, oh no, like, you've got this degeneration, right? You've got the D word. And degeneration is a big, scary word for people. But what a lot of people don't realize is that their tendons there's so much redundancy that's built into tendons that you can so often use the remaining healthy fibers and strengthen those up adequately and get a massively favorable outcome. But what a lot of medical providers use as their first line of defense to this is a cortisone injection, right? And so they'll inject the tendon with cortisone. It'll feel better temporarily. And then someone will say, oh, I feel good now, right? Like I got a cortisone injection in my elbow, right? For my tennis elbow, or in my Achilles, right? For my Achilles tendonitis. And it felt better. And then what happens? They go back into the activity that led them to that place in the first place, and it flares right back up. And so now all of a sudden they get another injection because it worked the first time. And so now I'm going to do it again, right? And then over time, that cortisone can actually cause more degeneration on the tendon, but we're not actually doing the thing that the tendon needs the most, which is strengthening and load and adequately doing the work that's necessary to get it back to that full tensile strength again, right? And so you and I know that as rehab providers, that the process of actually recovering from a tendon injury, of healing a tendon injury, is a slow, gradual process, and it's not something that a shot can ever fix, no matter what anybody says. And so that's one of the things that I think about in terms of conditions that are commonly mistreated in the medical system.
No, absolutely, man. No, I think you said something that was really cool about how with cortisone injections, like the lower down on the body that the injury is, that the tendon injury is, the less likely it is that a cortisone shot would help. So I thought that was a really good way of picturing it. I believe you alluded to Chris Johnson, who's, if you don't know Chris Johnson, he's a fantastic.
Chris Johnson, shout out, great mentor, great friend.
Not the ex running back for the Tennessee Titans, a running guru, physical therapist, but no, he told you something really cool about just how any weight bearing. Have you ever heard of a story where a weight bearing joint, a weight bearing tendon, had a good long term outcome from a tendinopathy? And you
from a cortisone injection.
I'm sorry, my bad. Yeah, from a cortisone injection. And across the room, it's everyone's looking around like, that's not something that I've seen a lot of good outcomes from in the low back and the neck and the shoulder. Typically, some pretty good outcomes. It's an interesting research topic that I haven't done a lot of research on, admittedly, but it's interesting to think about how weight bearing joints typically don't respond as well to cortisone shots as maybe things above the hip. So that's just something to kind of a tidbit to take away from this. You know, when you think about getting a cortisone injection, just think about that and really go through all your options there, and know that if you can take 3 words from this in terms of the tendon part of this talk. Tendons love load. I'm going to say that again. Tendons love load. Remember that. That's one of the best ways that you can take control of your own health care, take control of your own pain in terms of a tendon injury, and treat yourself in the best research-based way possible, is load that tendon up to its pain tolerance and do it with a progressive manner where you're continuously challenging that tendon to grow and get strong and get that tensile strength back that you mentioned. Yeah.
Oh, I love that. Yeah, I think in summary there, the closer a tissue is to the ground, the less likely it is to respond to a cortisone injection.
Boom. That's it.
I think that's really what it comes down to.
Write that down.
Yes.
That's it.
So I think that's good. So we talked about that and the conditions that are often mistreated. As a little aside to that, what do you see as being misdiagnosed? So people come into your office and they say, oh, my doctor diagnosed me with this. This is what I have. They told me to get physical therapy, right? And you look at them and you're like, that's not what you have, right? This is. I'm sorry, but your doctor was wrong, right? What comes to your mind when we say that?
Yeah, for me, I work with a lot of runners. One thing that I see misdiagnosed a lot would be bone stress injuries, for sure. So very classic one would be like a shin splint. People have pain on their shin. They might be told that it's a shin splint because everyone knows what that is. It's an easy answer. So then you get to diagnosing them. You have them do a couple tests that are specific to kind of expose that bone stress injury, and they're hitting all the points to give you a sense that there might be a bone stress injury. And then you start to talk to them about what they've been doing in the past, and you start to hear certain things that are, again, kind of red flags towards a bone stress injury. You hear about their training routines. They're not eating all of the right things. There are different systemic issues going on, and you start to realize that it's a bone stress injury, or at least there's a high suspicion of that.
Sure.
And one of the big keys to understanding that as a runner would be is like a very easy way of understanding it. Like if you're running and you have a pain somewhere on your body, like if it feels like a pinpoint spot and it gets worse and worse and worse with the more you run, as opposed to it warming up. Sometimes people will say, yeah, I'm feeling a little weird the first couple miles, but then it warms up. That's usually something you can run through, and we can have some conversations about how to improve that. But if it gets worse and worse and worse, the more you load it, that's a big green check for a bone stress injury. So that's one that I typically see a lot working with runners. So it's just something to be aware of when you're a runner and you're having this pain that's not going away. Ask them about that. Ask them, could this be a bone stress injury? Maybe they didn't think about it. So it's something that you want to be very apparent of, because that bone injuries are a real bugger, man. You got to treat that very differently than you would a muscle injury, obviously.
Absolutely.
So it's that's one that I typically see. Are there any for you that come to mind?
I mean, bone stress is a huge one. I think about it. What comes to my mind originally is specifically femoral bone stress injuries. So stress fractures or bone stress injuries that are in the hip and they are misdiagnosed as a hip flexor strain. And this happens in runners a lot, like endurance athletes who get a hip flexor strain. It's like, you did not strain your hip flexor. Like, that's not how that happens, right? Muscle strains happen in very ballistic, one-off situations, right? Something that's insidious, something that gradually comes on is 99 times out of 100 not a muscle strain type injury, right? So someone's like, man, I just have this pain or this tightness that's in my hip constantly, and it happens every time I run. It's like, God, you could be cooking a bone stress injury there, right? And what's super scary about those is that those can, depending on the location, can end up in emergency surgery, right? So if you have, depending on the risk, the injury site, right, that could be something that eventually turns into a full-blown fracture that you're into like a hip replacement now. Like, you know what I mean? You're like, yesterday I was running 20 miles. Today I had a hip replacement. It's like, that is not the situation you want to be in, right? So that one I feel like sticks out to me because I see a lot of misdiagnosed femoral bone stress injuries. And again, a lot of my training on that comes from Chris Johnson as well. Shout out Chris, his second shout out today, who kind of brought that to my attention and to light for me, in a very poignant way. I think, the other one that I think of that just comes to mind, no pun intended, is migraines. I think a lot of people are diagnosed with migraines and they are given like classic migraine medication that targets the vasculature around the brain, so the blood vessels around the brain, because classic migraines do come from that. But a lot of people are misdiagnosed with migraines, and actually their root issue is that it's all coming from the neck. It's cervicogenic. And so, it's not downplaying the severity of their symptoms. These people can suffer for years and years on end. And it honestly breaks my heart whenever I have somebody that is dealing with migraines, because I know they've been through hell. If you've ever had a headache, like a baby headache sucks, but like imagine a debilitating headache, that like keeps you in bed all day long. That's terrible, And so, I definitely empathize for those people. And the problem is that our system honestly misses so often that these problems are not coming from inside their brain and inside their head, but it's the musculature around that, And so understanding what to look for there, I think, is really important. And something that needs to be addressed in those situations too, to make sure like, hey, let's make sure this is not coming from your neck. Let's make sure that this actually is something that's coming from inside your head, because if it is, then you're probably on the best path right now. We can talk through management strategies, et cetera. But if this is actually coming from your neck, I'm gonna say girl, because I would say the majority of migraine patients that I see are female, but it's like, whoa, girl, we got a whole lot of work that we can do to help change your life just by working through and correcting the neck issues that we see there that are leading to these headaches, And so that's the other one that comes to my head. Well, JT, we got to wrap on this one here before we go today. I want to ask you, what is one piece of advice or some good news that you would like to share with the audience, something that they can take home with them? We've talked a lot about doom and gloom on this episode. We're off to a hot start, man. Just real uplifting, encouraging
That's what
news
we're all about
here. That's
here,
what we're all about. But let's leave the audience with something that's good, something they can take with them tomorrow as they're going into their appointments, as they're thinking about how to manage their own health. What's one piece of advice that you would leave them with?
Yeah, no, the reason we spent so much time there, man, was just to bring awareness to this issue. I think that's the first step, is bringing awareness. And then from there, it's just educating yourself on what's going on. And that's kind of where my advice comes in, is I think the best thing that people can do is to educate themselves on the options that they have. So many times that I hear, I hear patients come in and they come off like they felt like they only had the option of doing this surgery or doing this cortisone shot, or they were told that they need this sort of treatment that they might not have been comfortable with, but they're getting told by a doctor that they're like, oh, it's a doctor, I guess. They didn't even know that conservative care was an option. That's what pisses me off. That's what I want people to take from this episode. If anything, just know that you have options in most cases. Some cases, like we've talked about, yes, surgery is the absolute best option. We're going to get you better from that. But there are so many other cases where surgery might be an option, but it's not the only option. That's my biggest piece of advice. Ask your doctor, is there another option? If he's not telling you that there is, go ask another doctor, get a second opinion, be your own best advocate. You are your healthcare. Like treat yourself like your own doctor in a way. So yeah, just that's the one that's how I want to leave this, is just take control of your own healthcare, man.
I love that, man.
Yeah.
Take control of your own health.
Yeah.
It can be daunting. It can be intimidating. There's a lot to learn. And to you and I, this is second nature in a lot of ways to have these conversations. But some people might be a little just, I guess, not even turned off, but just, I think, even like kind of confused in terms of even some of the terminology that we used. And I think my one piece of encouragement would be to continue to learn, right? Continue to dive in and to learn as much as you can about your health, right? And, there's a lot of conflicting information out there as well. And so find somebody that you can trust, that you can have an open, honest conversation with, and ask them certain opinions about things. But then ultimately, your health is your responsibility, right? And so we're here to provide as much guidance as we can and help people make those best decisions for themselves. Yeah,
Absolutely, man.
Awesome, man. JT, thank you so much. We'll catch you on the next episode.
Yeah, man. Let's do it.
All right.